watching live Channel 24 KJAI, Mid-Missouri's news source at 10.
Good evening and welcome to Channel 24 News. I'm Bob Jackson.
And I'm Jan Myers.
Tonight we begin our four-part investigative report on the lack of access to health care in Missouri.
Thanks, Bob. And you're right. There's a big problem with access to health care in Missouri. There just isn't enough. And it's been getting worse. As you see here, 112 of 115 Missouri counties indicated in red don't have enough health care providers. Only St. Louis City and County and Jefferson County have enough. In fact, according to the Bureau of Health Workforce and Health Resources in 2024, Missouri ranked 48th out of the 50 states with just 22% of the number of providers that Missouri needs. And by population, Missouri ranked fourth worst in the country in primary care shortage areas behind California, Texas, and Alaska.
So what's the source of this primary care provider shortage?
Missouri has enough providers. The state just doesn't have enough doctors.
Physicians are aging out, or they are either retiring or dying. And as you will learn, this fact is a big part of the problem.
The reality is that our physicians that work for the organization are in the 70s and 80s because really just family practice doctors are few and far between. And so they have aged out of the population, and nurse practitioners have gratefully come in to see those patients that otherwise wouldn't be seen in primary care.
In addition, many other physicians don't want to work in rural areas. Missouri needs 476 additional physicians right now just to meet the needs of current citizens, and that number is growing every year.
So you say we don't have enough doctors, but let me ask you this. Do we have enough providers?
No, but there are 15,500 nurse practitioners in Missouri who treat patients every day. They could fill the gap.
Yeah.
But you may not know much about them.
We have a lot of areas, especially the rural areas in Missouri, that have no access to care. So as a nurse practitioner, I believe and I know that we can fill that gap in a very meaningful way. We can improve outcomes.
I see a nurse practitioner myself when I need medical care.
Right.
They are nurses who have additional medical training.
That's right. In fact, I have learned they have a lot of additional training.
Advanced practice registered nurses have advanced education. They include nurse practitioners, or NPs, as well as registered nurse anesthetists, clinical nurse midwives, and clinical nurse specialists. They are all nurses with advanced education in primary care or other medical specialties, and primary care providers are just what Missouri needs. But Missouri doctors don't think NPs are qualified to work alone, and they can't right now under Missouri law.
Wait, nurse practitioners can't work alone under Missouri law? What's missing here?
Quite a lot, Bob. You will hear about it in the rest of our investigative report. There is a lot more going on, and some of it isn't very pretty.
In fact, it's an ugly secret. In part 2 of our investigation coming up, we'll tell you why doctors think nurse practitioners aren't qualified and why NPs can't work alone in Missouri. Missouri citizens can change this. Be watching for part 2, and please share this report.
You are watching live Channel 24 KJAI, Mid-Missouri's news source at 10.
Good evening and welcome to Channel 24 News. I'm Bob Jackson.
And I'm Jan Myers.
Tonight we continue our investigative series on the lack of access to health care in Missouri. Jan?
Thanks, Bob. In our last report, we covered how Missouri ranks near the bottom nationally in access to health care, particularly in rural Missouri.
We also reported that because we don't have enough primary care physicians, Missouri has over 15,000 nurse practitioners who could fill that shortfall. But Missouri physicians don't think that nurse practitioners are qualified to do that.
Why is that? Is there a problem with their education?
Well, understanding the difference between physician and nurse practitioner education is important to understanding if NPs are qualified, so let's take a look.
Let's start with physicians. Med students get a pre-med bachelor's degree majoring in some science like chemistry. They then attend 4 years of medical school where they learn core knowledge like anatomy and biochemistry, mechanisms of disease, and clinical knowledge and skills. These include skills like stitching wounds and taking blood pressure. Interestingly enough, these skills are taught to them by nurses. They then become interns in hospitals where they prepare for 4 years of residency. They graduate with a medical doctor degree. During residency, interns start to focus on specialties such as internal medicine, emergency medicine, and family medicine, where they are often taught by nurse practitioners.
In my practices, I have done a lot of work with third-year residents. With third-year residents, I often was the only one actually training them. I had a fourth-year resident follow me as well. Now that I'm with the group that I'm with, I've been working with third-year medical students significantly, and often was, again, the only person actually training the third-year medical student in the psychiatry rotation.
Upon finishing residency, residents may become a primary care physician or pursue additional training in support of a specialty.
I find it surprising that nurses and nurse practitioners actually train med students and residents while in med school and residency. How unqualified could they be?
Well, that's the question, isn't it? What's really surprising is that nurses get years of training from doctors long before they become NPs.
Let's take a look at the education that nurse practitioners receive.
Nurses begin their education by learning anatomy, physiology, psychopharmacology, nursing research, and learning clinical skills like physicians do in med school, as well as vital signs measurement, assessment, and care planning. Upon graduation, they earn a 4-year Bachelor of Science in Nursing degree. Nurses then work, on average, 8 to 10 years as a nurse, either in a hospital or a medical practice. During those years, they work with physicians, developing nursing diagnoses and creating treatment plans for thousands of patients. Nurses may then decide to become a nurse practitioner. Advanced practice nursing programs consist of advanced theory courses as well as clinical practice, where board-certified nurse practitioners or physicians mentor, supervise, and train NP students during their clinical rotations. Upon graduation, they receive a Master's of Science in Nursing and pursue an NP specialty in family, adult, or acute primary care, or in psychiatry, cardiology, oncology, orthopedics, pediatrics, and more. NPs may also choose to pursue a doctoral degree for 2 additional years, graduating with a PhD in nursing or a DNP, a Doctor of Nursing Practice.
So it sounds like to me that doctors provide NPs with their own residency during those 8 to 10 years back when they were nurses. With all the extra NP education on top of that, I am not seeing why doctors think they aren't qualified to be primary care providers. Could it be malpractice?
We wondered about that too, Bob. So our team looked into malpractice. As Derek Leffert says, everyone makes mistakes.
The physician lobby for years has convinced legislators that physicians are the only way to ensure that the healthcare delivery is done mistake-free. And that's disingenuous in the sense that nurse practitioners aren't the only ones that make mistakes. Physicians themselves make mistakes, which is why we have malpractice insurance.
So let's take a look in a comparison of Missouri malpractice cases from 2015 through 2023, comparing 17,833 physicians and 15,500 nurse practitioners. Physicians were involved in 1,190 malpractice cases. Nurse practitioners were involved in 59 malpractice cases. Even when adjusting for the difference in numbers of providers between the two groups, malpractice numbers certainly don't indicate that nurse practitioners aren't qualified to fill the gap for numbers of primary care providers in Missouri.
I don't get it. There has to be something else going on here.
There is, Bob. And as our investigation continues in Part 3, it's beginning to look like it has nothing to do with whether NPs are qualified or not.
Rather, it looks like the real issue is something called the Collaborative Practice Agreement, where nurse practitioners in Missouri and other states must be supervised, and the NPs have to pay for it. And often, that's big money. Don't miss our next report, Part 3. Missouri citizens can change this. Be watching for Part 3 and please share this report.
You are watching live, Channel 24 KJAI, Mid-Missouri's news source at 10.
Good evening and welcome to Channel 24 News. I'm Bob Jackson.
And I'm Jan Myers.
Tonight, we continue with part 3 of our series investigating the lack of access to health care in Missouri. Jan?
Thanks, Bob. In our last report, we compared the education of both physicians and nurse practitioners in Missouri.
Upon graduation, it appears that both groups are prepared to provide primary care or pursue a specialty. But the lack of access to health care is really because nurse practitioners in Missouri can't practice without the supervision of a physician. They call it collaborative practice.
And you also said that this collaboration is mandated by Missouri state law?
Yes, Bob, it all has to do with what's called the Collaborative Practice Agreement.
Here's the way it works. By law, each state defines and enforces one of 3 practice models that determine the level of autonomy with which an advanced practice nurse can evaluate patients, diagnose conditions, prescribe medications, and manage care. These models are full practice authority, reduced practice authority or transition to practice, and restricted practice authority. Nationally, 29 states and the District of Columbia carry out full practice authority. In these states, there is no supervision by physicians or collaboration with nurse practitioners. NPs are able to work independently just as physicians do. This is the model that is recommended by the National Academy of Medicine. A second model implemented in 11 states is called reduced practice authority or transition to practice. In this model, physicians supervise new nurse practitioners in at least one area of NP practice and allow for a short probationary period, something like 2,000 hours of collaboration, before NPs are free to practice independently. Finally, a third model is imposed in Missouri and 10 other states called restricted practice authority. This model requires a strict collaborative agreement where NPs can't practice without the supervision of a collaborating physician. As you can see, Missouri is surrounded by 4 full practice authority states and 2 reduced or transition to practice states. Missouri advanced practice nurses, which include nurse practitioners, believe Missouri should graduate to the second model by enacting transition to practice.
We're looking at doing something called transition to practice. We're supporting about 2,000 hours of practice where you're working with someone who is more advanced in their knowledge and will work with you, and someone who's right out of medical school and their residency. They may or may not get it right because they're going to focus on what they learned in their residency programs as far as what they should do. Well, the same thing is true with nurse practitioners when they come out of graduate school, to make sure that they really understand what they're doing.
However, this requires a change in state law by the Missouri legislature. We'll take a closer look at that in our next report.
Now it's starting to make sense. Since we are losing physicians, state law prevents nurse practitioners from being able to close the provider gap.
Collaboration means the physician must review approximately 10% of the NP's patient medical records each month. But since the records cover past cases, with the time it takes, and since many NPs don't see their collaborators, it's difficult to get that done. The other thing our investigation revealed is that collaborators can often be not very collaborative.
They cost me a lot of time. They cost me precious treatment time with my patients, micromanaging of what I did with the patients. No matter how innovative my treatments were, they were against it. So that meant that I couldn't actually use my skill set. So I had to go through 4 different collaborators in order to get to one that actually understood what it meant of what I was trying to accomplish. It was all about, I just want you to document exactly what I tell you to, and then that's all that matters.
So some of the ways that I was impeded or held back due to collaborative practice was I couldn't get things done for my patients unless my collaborator agreed with it. And in order to do that, I had to get hold of him. And when he's a state away, that's pretty hard to do. Most of my practice I did through online resources with specialty providers that was available. If I had questions, I would be able to upload everything I did for the patient. They could talk to me, give me a plan, and we worked together. So that is really the only way I was able to serve my patients in the way that they needed.
The first time I really found an issue was when he moved on and semi-retired, and I got a new collaborator. I had been trained to do Nexplanon implants and for birth control, and my new collaborator had never been trained. And although I had trained with physicians and I'd done it for 5 years, because he wasn't trained, I could no longer do that.
But Bob, we also learned that designated collaborators aren't really needed because in reality, nurse practitioners collaborate with lots of other providers.
Yes.
I collaborate on a daily basis with the other nurse practitioner that is a partner in business with me, with surgeons, ears, nose, and throat doctors, cardiologists. I have friends that are in obstetrics that I can talk to. I have a list of people in my contacts if I have a problem that I can talk to, not just the collaborative practice physician.
I've had several collaborative practice arrangements in my career, and I've been lucky enough to be able to find a different one when the ones that I had didn't work. And basically those didn't work because the providers that I worked with, I felt provided insufficient care. I mean, they just weren't up to the standards that I thought they should be in order for what patients were receiving as far as good care. I currently have had a collaborative practice arrangement with one physician for 12 years now. We work very well together. We bounce ideas off of each other all the time, and really that's what collaboration should be. It shouldn't be mandated. It should be something that we just do inherently to take care of patients and give them what we need. The fact that I'm mandated to have on a piece of paper that I have to have a collaboration is just really archaic. I collaborate with all kinds of providers every day, from cardiologists to endocrinologists, rheumatologists, family practice, internal medicine. It can go on and on. GI specialists, anybody that needs something, I will find out who they need to be seen by.
So it appears that mandated collaboration is restrictive and unnecessary. Earlier you mentioned that NPs have to pay for this, and pay a lot.
If NPs don't work in a hospital system, they have to find their own collaborators. And in rural areas, that can be difficult and expensive.
Every nurse practitioner in Missouri has to have a collaborator. In large hospital systems such as these, physicians are appointed to serve as collaborators, but the physicians are paid out of the NP's salary. In rural areas or where nurse practitioners own their own practices, they have to find their own collaborators and must pay whatever the physician charges. NPs really have no choice, and sometimes the fees are very expensive.
What people don't realize that the collaboration comes at a cost. So there is no limit to that cost. Basically, the cost of collaboration is between the physician and the nurse practitioner or the advanced practice nurse. And a lot of times it is basically what the physician says it is. So we have no recourse. I've heard from my colleagues that their cost for a collaboration is nothing, to maybe a Christmas dinner once a year, to personal experience of seeing physicians making over $4,000 a month to be a collaborator. So it's a business for the physicians. And in Missouri, they can have up to 6 full-time collaboration agreements. So it's a business. It's no longer a need for supervision. It is a downright business.
For us, I had to negotiate with the collaborating physician, where literally per psychiatric nurse practitioner for a full year, it equates out to $25,000 per psychiatric nurse practitioner. That's $50,000 a year that they are getting for doing the collaboration, where basically we give them the charts, we make sure everything is set up for them so that they don't miss a beat in terms of the 10% of charts that they're supposed to look over. So that means that really, in essence, they have very little things that they need to do in terms of overseeing the large amount of patient population that we see.
When I interviewed this one physician, he told me that he had 19 nurse practitioners in the state of Illinois. And so I asked him, why does he support the role of the nurse practitioner? And he actually told me he didn't. He told me the reason that he was doing this was strictly for the money. He said he was able to retire from his practice and solely collaborate and made almost $400,000 a year. So that was like a kick in the gut for me because I felt like I was a cash cow for someone who didn't really care about the profession or taking care of patients, but someone that instead cared about their pockets. They weren't like me, passionate about healthcare.
Well, Jan, I almost don't know what to say. It really is all about the money. I'm surprised that nurse practitioners don't speak up about this.
Well, if you do speak up, you may be sorry you did.
We had a system-wide meeting with the physicians, nurse practitioners, and PAs to discuss the physician shortage because there's a big shortage. And being who I am, I raised my hand in that meeting and I said, because we have such a physician shortage, would the system support full practice authority? 3 weeks after that, I found myself in a situation where I was told I no longer had a collaborator. That broke my heart because that was, my community. And I didn't realize why I didn't have a collaborator. I asked to sit down and talk to the people that I worked with about it, and they said that was not an option. About 6 months later, I ran into that collaborator, and he said, "Where did you go?" And I said, "I was told you didn't want to work with me." And he said, "That's not true." And I realized at that time that the time frame after our meeting and what probably brought this about.
Wow, what a shame. With the money involved, I see now why physicians don't want to give it up.
It is a shame, Bob. And in our next and final report, we'll learn what happens when a nurse practitioner loses a collaborator. They become unemployable, even though providers are needed more than ever. We'll also examine the political issue as to why NPs can't get a bill through the Missouri legislature to change this. You'll hear all about the medical lobby that is blocking it. Missouri citizens can change this. Be watching for part 4. Follow and share this report.
You are watching live Channel 24 KJAI, Mid-Missouri's news source at 10.
Tonight we conclude with part 4 of our series investigating the lack of access to health care in Missouri. Jan?
Thanks, Bob. In our last report, we examined the physician-nurse practitioner collaboration agreement and the exorbitant expense many NPs must pay to practice. But what's worse, NPs are truly at the mercy of physicians. If their collaborator retires or dies, they are out of work.
We want to be able to improve access to care for the patients in our communities. A lot of people don't realize that if your physician is gone, you can't practice. And we have 3 clinics in our area, Southwest Missouri, that their physicians are getting ready to retire. When they retire, those people won't even have their nurse practitioners because they don't have a physician collaborator and they're having trouble finding one to replace the one that's retiring.
When I graduated from Mizzou as a family and geriatric nurse practitioner, I opened my own clinic. I was doing well, had probably over 3,000 patients on my panel. I had a clinic that I owned that was the first doctor's office that was built in my town of Lesterville. And after that happened, I had a collaborative physician who was actually from Iran. And when he was on a J-1 visa, and when he received his visa, he immediately left my practice, which left all of my patients without prescriptions, without any ability to have follow-up, and my clinic was forced to close.
I used to have 4 clinics. 3 of them were rural areas. And because of the collaborative practice issues, I had to close 3 of those practices. The collaborative practice arrangements limit us in so many different ways that we just can't take care of our patients. But the fact that I had to close those clinics is a really big deal.
Wow, I can't imagine the financial loss and the loss to patients when you have to close multiple clinics.
No question, Bob. In fact, it's forced some nurse practitioners to escape Missouri and open clinics in other states.
So I own a psychiatry practice in the state of Iowa where I don't have to worry about collaborative with a physician, right? So I don't have to worry about whether or not I'm supervised by a physician. That doesn't exist. Iowa has had full practice authority for nurse practitioners for years. And still yet, we see no data that's out there that says that nurse practitioners are doing any worse of a job in terms of taking care of the population at all. And in fact, if I were to say, there are 30 other states that have full practice authority, and we don't hear the stories of it being an astronomical mistake that nurse practitioners have full practice authority. So in the state of Iowa, I can do the necessary care in the necessary time frame that it takes to provide great care for the patients of Iowa. This is fantastic.
What about the physicians, Jan? Do they have anything to say about the issues our report has uncovered?
Despite our efforts, physicians in Missouri won't speak on the record about collaboration agreements, what they get paid, or the closing of rural clinics. But Jared Fleming, our Capitol reporter in Jefferson City, has more on the legislative blockade.
That's right, Jan. Here at the Capitol, Derek Leffert has more to say regarding obstacles to getting corrective NP legislation passed.
I think most everybody knows that, all the legislators that we talk to on a regular basis know and understand that nurse practitioners can be an instantaneous solution for access. But I think where they stop short is that there's an unwillingness for them to say, okay, we're going to go ahead and let you do what you're fully trained and educated to do, because the physician lobby for years has convinced legislators that physicians are the only way to ensure that the healthcare delivery is done mistake-free.
The physicians' lobby Derek mentioned is made up of various medical groups that lobby against any legislation that disrupts the status quo of Missouri physicians. The physicians' lobby has convinced many legislators that NPs aren't qualified to practice on their own, even though 29 states have proven just the opposite. In addition to the physicians' lobby, Missouri citizens will be surprised to learn that a number of our state legislators are also physicians, which appears to many to be a conflict of interest. The biggest conflict of all is that the Missouri Speaker of the House, John Patterson, is also a physician. He's the one who determines what legislation comes up for a vote in the House and what doesn't.
So as it relates to physicians in the legislature, there has been, doctors in both the House and the Senate for quite some time. That presents a unique set of challenges because the Speaker of the House is very influential as it relates to the legislative process and has the ability to, affect the referral of bills, the passage of bills, even to some extent, what goes on in the Senate, because, they can hold things hostage from the House until things get done in the Senate. So despite what people may believe, there's not a huge number of physicians in the legislature, but those that are in the legislature have been extraordinarily influential in stopping progress that we've made, that's necessary for nurse practitioners to be able to practice their level of training.
Physicians in the legislature working against nurse practitioners does seem like a conflict of interest.
That's why we mentioned it, Bob, but it's not publicized enough. Missouri voters just aren't aware of it.
Jared, are you finding there are legislators who do support legislation that would give APRNs transition to practice?
There are, Jan. I spoke to two of them this morning.
So glad to support nurse practitioners and the work they do. They serve a vital role in Missouri's healthcare system, in particular in rural Missouri where I live, where nurse practitioners are the folks that you go and you see every time you have an issue. And the fact of the matter is, I haven't seen an MD in years, and I couldn't be happier with the service I get from our nurse practitioners. We have a healthcare crisis in rural Missouri, and we have trouble getting great qualified folks, and the ones we do are generally nurse practitioners, and they offer tremendous care to their patients in rural Missouri. We're glad to support them.
I think the federal statistics have showed we're going to have about a shortage of 1,300 doctors next year, and nationwide it's going to be even worse when you factor in a lot of the retirements from the baby boomers. We see nurse practitioners leaving the state of Missouri, going to surrounding states where they can actually do what they were educated and trained to do. And here, they're still handcuffed by some of these regulations that were put in place many, many years ago. So ultimately, if we're going to fill that gap of these 1,300 doctors that are needed in our state, it's been proven time and time again from our states that are to the right of us, to the left of us, Republican states, Democrat states, that this is the thing that is actually lowering the insurance rates. It's lowering healthcare costs. It's increasing the time that you can get in there and see a doctor. It's increasing the outcomes, the patient outcomes. So if we're going to prioritize the people over whatever it may be, the lobbyists and the third-party interests, this is the bill that we have to get going.
So I thought we might learn something from a nurse practitioner from one of those 29 states that already has transitioned to practice.
I had a Zoom chat with Julie Balk, a nurse practitioner from the Salt Lake City area. Utah was also a restricted practice state and, like Missouri, had a similar lack of rural healthcare access. In 2023, the state of Utah changed the law, dropped their collaborative practice agreements, what Utah called its consultation and referral plans, and Utah nurse practitioners began to work independently.
And so the concern or potential concern that, oh no, if we let nurse practitioners be unsupervised, people are going to get hurt, or our controlled substance prescribing is going to increase. That did not happen.
With transition to practice in Utah, things got much better overall. But like here in Missouri, collaborative fees had also been an issue.
Every time we have reduced barriers, we have not had any problems with poor quality of care. We have not had more malpractice insurance issues. In fact, our DOPL, or Department of Professional Licensing, complaints or grievances are far less for nurse practitioners than our physician colleagues. So one of the concerns with requiring payment for a consultation referral plan there's two aspects. One is actually a restraint of trade issue, but there was also the concern, not just with safety of care, which we know was not an issue, but that paying physicians for that service, removing that consultation referral plan, would also hit them in the pocketbook. You cannot take away that money and concern for controlling someone else's practice. We were also taking away a revenue stream for those physicians who had control of perhaps a rural environment so that they could limit anyone else's ability to provide that service in their community.
We also spoke with APRN nurse anesthetist Josh DeLazier, who works both in Oklahoma as well as in Missouri. Following up on Julie's mention of restraint of trade, Josh thinks what is going on in Missouri is extortion.
Well, if we are required to have a collaborative practice agreement with a physician, then the physicians know that we can't work without them writing the agreement. So what happens? We get extorted for money. They know that we can't work without them, so they bill us. They send us up to $150,000 a year just to have the ability to work in the state of Missouri. But the majority of the time, to have a collaborative agreement is going to cost you money, and you're talking up to 6 figures. And that's not putting the patients first. That's the abuse of politics to extort the advanced practice nurses. Like they said, we've all worked and we've gotten a great response in the committees, and then Missouri politics comes into play and we never get them out for a vote. If it goes to a vote, it rolls. It's just too common sense, and then people actually care about the patients.
Jan and Bob, I had one final interview with another nurse practitioner here at the Capitol. You really have to hear her story. Sheila Armbruster is a nurse practitioner in the Boot Heel in Southeast Missouri. She has been a nurse and an NP for 38 years. She has also had to close practices because of overwhelming costs. Listen to her story.
I've served street people. They do have some Medicaid. I serve people that don't have any insurance. I treat a lot of people for free. I've made less money as a nurse practitioner than I did when I was an RN, and it's because with the nurse practitioner title, I can treat them for everything, and they are dying. I've got one right now that is in respiratory failure. He has probably 3 or 4 months left to live. He's a grandpa, and he's raising his grandchildren. Oh, I do actually see patients in their homes. Yes, I travel to Cape Girardeau, and I see people from my previous office. I see those 5 patients from there. The difficulty for me is the cost of the collaborator. I'm paying 3 times my rent to be able to have a collaborator. Well, I've had 2 strokes, and I've tried to cut down on my patient load. And so I've closed 3 clinics and just have the 1 clinic in Sykeston. And I can't see enough patients. I can't see enough patients to pay the collaborator fee, my rent, utilities, my insurance, because we have to have the liability insurance. When you're trying to cut down on your workload, then you can't make very much money, and so you have to stay on the rat wheel this amount of time to be able to afford to pay the collaborator along with all the other business bills. I'm almost 70 years old, and I would work till I died, honestly, at this. I just have a heart to take care of people. I really don't care if it's people that are wealthy or poor or whatever. I just need people to be taken care of here in Southeast Missouri, and we need that so badly to be set free so we can help others.
Wow, a nurse practitioner who makes house calls and works for free. Her patients are lucky to have her.
Well, Bob, I think our investigative report has revealed that there is a solution to greater access to health care in Missouri. With your help, Missouri can go from this, with nearly all counties underserved, to this, with just a handful needing help. Here's what we need to do. First, use your cell phone or handheld device and take a picture of this QR code. That picture is a link that will allow you to, number 1, close the gap on the number of providers that Missouri needs. Number 2, let Missouri's 15,500 advanced practice nurses and nurse practitioners fill that gap like they have in 29 other states. Number 3, make that happen by eliminating collaborative agreements with physicians so APRNs can work independently to the full extent of their training. And number 4, and here's where Missouri Citizens Action comes in. Email your legislator and urge them to vote for Senate Bill SB 979 and all other pending nurse practitioner legislation. Here's how you do it. Click the QR code you photographed, or if viewing on your phone, in the comments, click the logo you see there. Either will take you to a letter you can email to your legislators asking them to vote in favor of this legislation. Passing this legislation will only happen if Missourians unite on this issue. Share this video with your social media contacts and urge them to vote and share this video as well. Together, we can challenge the political process and open up access to health care for all citizens of Missouri.